I start off by reminding members around the protocols regarding the use of electronic devices, and may begin by welcoming members back to the committee after summer recess for the beginning of our autumn term. Can I in particular welcome our new member, Ian Milne, who's replacing Dathly.
Thank you.
You're very welcome, Ian.
Thank you.
You will find that we will be a very fun committee as we progress through the term, so you're welcome and joining us today. Members, have we any apologies from anyone? I know Trevor is not late. I haven't heard whether he will not be here or not, but I assume he will at some stage. Anything else anybody wants to bring up? Nope. Okay. If we move on then to item number 2 on our agenda, which is the draft minutes of the meeting of Thursday, the 15th of September 2016. No, that's not right. It's of the Thursday, the 30th of June 2016. That's on page 5 to 8 of your meeting pack. Are members content with those minutes? Yep, agreed. Okay, thank you. Item number 3 is chairperson's business. I just have a few items that I need to get approval from yourselves with. As chair of the committee, I've been asked to attend several events and speak at several events and launch several events, so I'm just going to run quickly through them here and seek your approval of that. The first one is the Royal College of Speech and Language Therapy Conference on the 19th of November. They have asked me to do the welcome at that conference. Second one is the launch of a report reducing pressures on hospitals on the 11th of November, and that's with the College of Occupational Therapists. The next one is the British Dental Association on the 25th of November. They've asked me again as chair of the committee to speak at their conference. And then we have the UK Home Care Association Northern Ireland Providers Forum on the 8th of December. And then finally the Royal College of Paediatrics and Child Health at their launch of their State of Child Health report on January the 26th, 2017. They're ones that came through quite recently and over the summer, so it's just a seek committee's approval for those. Is that okay? Thank you very much.
Chair, I would like to raise some, maybe I'll take your guidance on it, whether now or any other business. Just the fact that I'm concerned, and I know speaking to other members are concerned, that we were to have our presentation by Professor Bengoa, which has been postponed. For me, I think the delay is concerning. It would certainly be of interest for the committee to know the reasons behind the delay, whether it be from the Minister, the Department or the Executive. So perhaps we could write to the Minister asking clarity on when we will have the presentation, because it's so important, and time is marching on. So.
Okay, I understand, and I thank the member for that. I think that everybody around the table would have the same concerns. I know it's part of our Forward Work Programme, which we'll discuss when we get to the Forward Work Programme, and I know from the Minister at Question Time this week had said that I think it's imminent that we are going to get that report from her. So if we leave that to our Forward Work Programme, and then if we want to decide whether we want to write to her again, we'll do it at that stage, if that's okay with you, John. Thank you.
Sorry, just to be associated with those comments, I was going to come in later in a similar vein. I think it's important that we do the presentation on the report rather than recommendations arising from the report.
Yeah, I understand that. Thank you. Thanks, Mark. And as I say, we'll do that with when we get to our Forward Work Programme as well. I just welcome the members into the public gallery, and can I also advise them of the protocols around electronic devices. Please put your electronic devices onto airplane mode or silent. Well, airplane mode definitely, because 3G and 4G cannot be used in here in this chamber. Nor are you allowed to take photographs or do any recordings. So there is Wi-Fi available, and you'll find details of that. Okay. Okay, that ends chairperson's business. I have no further on that. Item number 4 is an overview briefing by the Patient and Client Council. I advise members that the Chief Executive of the Patient and Client Council is here today to brief the committee on the work of the Patient Client Council, including current work streams and priorities. May I refer members to a copy of the Chief Executive's presentation at pages 11 to 16 of the meeting packs, and advise members that a copy of their most recent annual report on accounts can be found at 17 to 108. So you're very welcome, Maeve and Louise. It's good to see you. And I'll just hand it over to you if you want to give us a brief.
Okay, well, thank you very much, and thank you very much for the opportunity and invitation to address the committee today. Some of you around this table will be familiar with the work of the Patient and Client Council, and I'd like to take the opportunity to thank you for your ongoing support. Others will be less aware of our role within health and social care, so I thought it was a good opportunity to give you all an overview of our work. I'd like to outline some of our key priorities and also just describe some of the ongoing challenges we are experiencing to secure service change for specific groups of patients, particularly with long-term enduring illness. The Patient Client Council has 4 statutory functions. 1, to represent the interests of the public to the health and social care system. 2, to promote involvement of the public. 3, to provide advice, to provide assistance to individuals making a complaint relating to health and social care. And 4, to promote the provision by health and social care bodies of advice and information to the public about the design, commissioning and delivery of health and social care. The Patient and Client Council is the independent voice of patients, service users, carers and communities. And we work with a wide network of people to ensure that their voice reaches the ears of decision makers, even when they have something difficult to say. We gather and share our evidence, both good and bad, in an independent and transparent way, and we only speak about issues where we have an evidence base to do so. We have a small team of about 30 staff, and over the past 7 years, we have spoken to almost 35,000 people who have contributed to our 62 reports. We have supported 9,874 people to make a complaint about an experience in health and social care. We have a membership scheme with 12,000 people have joined as members, and 4,500 people have attended Patient and Client Council events across Northern Ireland. It is through these conversations that we have published a wide range of reports to reflect people's views on subjects such as the People's Priorities, which is a report which tells us and the health and social care system what people consider to be important about the services. A report on the older people's experience of domiciliary care, the experience of older people looking after family with a learning disability, the experience of people living with chronic pain, and the experience of people living with rare disease. We have actually captured all of this work in a report named The People's Voice, which we'll share with the committee and our MLAs next month. We just have, that is literally just hot off the press, and we're really delighted to share that with you. We have a number of issues we are focused on at the moment, and these issues are a priority for us because they are a priority to the people we've spoken to. Waiting times. The length of time people have to wait either for diagnosis or treatment is too long. Behind every waiting list statistic, there is an individual or family who cannot recover the lost days or the medical implications of waiting for prolonged periods of time for treatment. People recognise that there will be long times for healthcare treatment. However, the information given to patients regarding times is often unreliable, and people are waiting much longer than they had been led to believe would be the case. This leads to frustration and a breakdown in trust in the system. The Patient and Client Council believes there is a need for good, accurate information about waiting times and alternative options available to people. It is essential that people can make informed choices and plan their lives accordingly. The Patient and Client Council worked with the service to produce information on the average waiting times for emergency departments across Northern Ireland, and this is now available on NI Direct, and we'd like to see similar information available on all waiting lists. Secondly, complaints. We annually support approximately 1,000 people to make complaints about a vast range of health and social care issues. There are 4 constant themes in the areas about which people complain. They are treatment and care, communication, staff attitude and waiting times. There is also consistency in the service areas that people complain about, including the medication prescribed to them, care at the end of their life and care of the elderly. Our annual complaints report will be published next week, and we'll share this with the committee. We would ask the committee to view complaints and their reporting as a valuable source of information on where services can be improved. Health and social care organisations must find a way to listen to people when they have something to say. People have to wait too long to have their concerns heard, leading to formal complaints. Organisations must find a way to formally hear people at the moment they have a poor or indeed good experience. The result will be fewer complaints and improved services for all. The demand for more and better advice and information about health problems, care and treatment choices has increased. People want to be more involved in their care, and information to allow this to happen should be accurate, up-to-date and reliable. Access to good information is a key component of high-quality care. Since 2009, the need for this information has been a recurring theme in our work. Without access to good quality information and feedback, patients and service users, including carers, are unable to make informed choices about their health, treatment and care. In 2015, we welcomed the launch of an accredited information portal through NI Direct. However, we would wish the development of the portal to continue at pace to reach equivalence to the service available to other NHS patients in the rest of the UK. It takes a long time to get change in the system. Our work with service users has resulted in some positive sustained service change. For example, in our My Day, My Way project in 2011, we spoke to over 1,000 people with a learning disability about their experience of attending day centres that provide opportunities for learning life skills and recreation. The Health and Social Care Board used the findings in this report to inform its review of day opportunities, which is currently being rolled out across the 5 health and social care trusts. In 2014, we spoke to over 2,500 people who are living with chronic pain. Our report, The Painful Truth, has been recognised internationally for its contribution to understanding the patient experience of living with pain and is helping to shape international and national policy. We have seen pain management being included in the commissioning plan for 2016-2017, where an extensive list of priorities has been attached to chronic pain. On behalf of the people who worked with us, we are very pleased on their behalf on these outcomes. There are, however, some issues we have been working on for some time that have been more difficult to get service improvement. There are 4 of these. The first one is endometriosis. Endometriosis is a condition which affects around 25,000 women of childbearing age in Northern Ireland. However, there is no accredited endometriosis centre or even a fast-track referral pathway. Since 2013, the Patient and Client Council has been supporting women with severe stage 4 endometriosis to get this service improvement in place. This is a health inequality which needs to be addressed. On behalf of the people we've been working for, we have asked for and will continue to ask for the prioritisation of a specialist endometriosis centre to support women with endometriosis and an awareness campaign on the condition among GPs and young women. ME and chronic fatigue syndrome. ME is a condition that has puzzled healthcare professionals for many years. For many years it has been debated whether it was actually an illness at all. It is officially recognised by the World Health Organization. Specifically, there are more than 7,000 diagnosed cases in Northern Ireland, with 10% of patients suffering moderate to severe symptoms. The Patient and Client Council has worked to get more recognition for people with ME to improve the existing services. The main priorities for these service users are that patients are given a proper diagnosis using a standard clinical method that will establish a proper baseline for treatment, and there is a specialist care centre in Northern Ireland for the diagnosis and treatment of people with ME. The first step in this process is the reappointment of a secondary care medical consultant to enable proper, timely diagnosis and to support GPs with the treatment and care of patients. Recurrent miscarriage. We have spoken to many women who have experienced miscarriage. It is evident that miscarriage, particularly recurrent miscarriage, can affect women emotionally as well as physically. Although there is evidence to suggest that counselling is necessary after bereavement, specialist counselling is extremely limited and in some parts of Northern Ireland non-existent. Currently, women have to qualify for a referral to a specialist miscarriage centre in the UK. It can be difficult to get such a referral, and for some it is upsetting to have to travel to another country for advice and/or treatment at a vulnerable time. Others also noted that it is distressing to have to compete for a referral based on a strict criteria. A dedicated recurrent miscarriage clinic and access to bereavement support services are important to improve the current provision. Mental health and learning disability services. The Patient Client Council has worked alongside service users and carers of people with a learning disability and enduring mental illness to ensure that the implementation of service change has reflected the opinions of those who access these services. There has been significant progress made, and we're grateful to all the people who have worked with us over the years to achieve these service improvements. There is still work to be done. There is one particular group we have sought to be heard. They are older carers. As we see people with complex mental health and learning disabilities living together and residing in the community, we now have many more older parents and carers who are looking after them. These dedicated carers provide an irreplaceable support to our health and social care services with limited help or their own needs. In speaking to them, their main concern is what happens to those they care for after they die or are no longer fit to provide care themselves. Future planning is a key to this and should be a major priority for how we look at the most vulnerable in our society. In closing, I'd like to thank you for the opportunity to address the committee. We'd ask for your support to prioritise the issues which people have told us are important to them. The patient and their family should always be at the centre of health and social care services. Embedding the patient experience as part of improving healthcare is now included in the Northern Ireland Assembly draft programme for government. The Patient Client Council welcomes this. This approach echoes our values and the approach we have taken to our work. We recognise the financial pressures that the health service is facing. However, not all solutions require additional funding, but rather a fresh approach to providing services. Greater involvement of patients and service users in the co-design and evaluation of services alongside decision makers and clinicians will be essential in finding cost-effective, sustainable solutions. Thank you very much.
Thank you, Maeve. Louise, have you anything to add to this time? Or? Okay, thank you. I know definitely through sitting in Health Committee through the last mandate as well just how invaluable the Patient Client Council is, and I suppose you touched on it there about valuable sources of information and some of the publications that you have made around health and social care and the needs out there for that client group. I'm glad that you mentioned their endometriosis again in the last mandate. That was something that we wanted to pursue, and we wanted to see some sort of service put in place for that. I know that that's such a big problem here within Northern Ireland, so it's good to see that that's being pursued as well. The committee in itself, when we have been discussing our priorities for going ahead, we've looked at the issues around mental health and the issues around primary care. And I suppose in particular maybe want to touch on mental health in younger people, and I know that there's a bit of work is being done on that, and I just want to know if you had some input onto that about younger people and them having to make complaints about the barriers that they face within the system.
Yeah, and actually we have just completed a piece of work ourselves looking at how younger people make complaints about their experience of health and social care. I think what's really important is that people get the right support to make a complaint, and that we work alongside the many children's organisations that are providing advocacy to children on a regular basis to make sure that we hear the voice of children, but also that they are supported to make that voice heard. So what we've been looking at is how do we make sure that when children come to us, that we get them the right support to make a case, because the feedback we have is that the process is very bureaucratic, it's very slow, and it's very frustrating. And I think it's, that in itself could put people off. So it's really important that we do have a system in place that young people can feel confident to make a complaint, but also confident that action is going to be taken as a result of their complaint.
I was also reading, I was reading through your notes as well, about your prioritised and looking at priorities and looking at homelessness and people. And I know that I have attended events to do with homelessness and how that affects mental health as well.
Yeah.
Just if you
Yeah.
any work that's being done on that.
Yeah, I think that homelessness is a really multi-agency work needs to take all of that forward. And we were, again, welcomed the setting up of the multi-agency group to do that. And we were really happy that some of the work that we had done had kick-started some of those discussions. I think the whole, we need to view mental health, as I said in my piece, a lot of work has already been done. I think more needs to be done, specifically looking at the requirements for young people. And I think homelessness is one area, home treatment's another area, working with schools. So it really requires an interdepartmental approach to it. And we're really pleased that some of the work that we've done will be able to inform some of that work going forward.
I think it also will inform. I know I met recently with the probation board as well.
Yeah.
And I think if we look at mental health and the journey that some people go on who have mental ill health, I think that it's something that we could save a lot of people from a lot of pain and misery later on in life. So I encourage and I welcome any of the findings that you might bring out on that, and the advice then that you'll be giving to the department. And I know through our briefings as we go forward as a committee, I know that again you will be invaluable in bringing information to us as well. I have a few more things, but I'm going to open up to the members first. I have a list. I have Joanne first, then Jerry, then Paula, then Pat, then Catherine. So anybody else want to signal, let me know. So Joanne.
Thanks, Chair. Can I also thank you for your presentation? As you know, I'm very aware of the work you do, especially around support for fibromyalgia and ME patients. And I know maybe you touched on this, the things that you're doing. I think proper diagnosis, specialist care in Northern Ireland, reappointment secondary care specialist in conjunction with the GP. Sometimes I feel they're the silent voice, and with 7,000 patients, Boston McLaren Interest, my sister's one of them, and many of our constituents are affected, and they do feel that nobody's listening. And just to say that you're usually at events they're supporting with it. So could I maybe ask, other than what you've touched on, Maeve, could you perhaps give us an update on what tangible things are happening, because they seem to be rapping at doors and things, but they keep getting closed in their faces, and this leads to frustration and, as we know, increases the problems with mental health. Because if you're ill, you know you're ill and nobody's listening to you, that exasperates that too. So could you maybe update us on
Absolutely,
what's
yes.
happening?
I'll pass over to Louise, who's been
Okay, I'll
working
take it in
directly
two
on this.
parts. First of all, I'll talk about fibromyalgia, because I think that's a good news story. We just this week released a report on the experience of people living with fibromyalgia, but whilst we were producing that report, we were working with the patients and with the Health and Social Care Board to develop a completely new care pathway.
And you did a lot of work with Hope for Fibro and ME, I gather too, which
yes,
is
and the
another
support
very
the
successful
support
group.
groups were involved in that, the service users and their carers, and there was a great deal of leadership shown by the Public Health Agency and the Health and Social Care Board. So that's a really good example of co-design in action, where they're currently sitting down around the table actually developing a completely new care pathway for fibromyalgia. So I would hope that that will make a difference from primary care right through secondary care for people who experience fibromyalgia.
Right. Maeve's points about reappointments, specialism, conjunction educating GPs.
Yeah.
How are we with that?
Yeah, with that, on fibromyalgia, I think we have made progress. In a sense, we've kind of separated the two, although we recognise that some people have a dual diagnosis. ME is a completely different kettle of fish, in that ME patients are very much outside of health and social care system. They have no secondary care support at this point in time, and there has been no progress in getting that secondary care consultant. It's something that we have been lobbying for. Some GPs have a better understanding of ME than others, and that's what patients tell us. But again, there's a big variation in that, and patients feel very isolated and very unsupported. So we have been, in the last couple of years, supporting the patients and the support groups to have their voice heard, and not only heard but listened to in that process. And there's a lot of discussions going on informally as well as formally at the moment to try to get the part-time secondary care consultant in place. Also, there is discussions around a new clinical trial, which we're hoping to get off the ground. Again, that will take time. And one of the things we're looking at is also doing a gain audit around the experience of people of the implementation of NICE guidelines here in Northern Ireland. So those are three things that we are actively working towards. At this point in time, I have to say, we haven't made as much progress as I would have liked.
You're frustrated as a patient.
Yes, but we are working alongside decision makers, and there's a lot of people taking an interest in this now that it wouldn't have been a few months ago, so that's hopeful. So it's something that's very much on our agenda, and certainly our experience of working with issues is there's usually someone working on a particular condition in the system, but AME is unique in that they don't have a service. The only secondary care or only consultant service that's available is actually a private consultant who comes in from England once a month or once every 6 weeks, and the patients pay for that themselves.
Yeah, they have to fund it themselves.
They have to fund that themselves, or the support groups fund it. So they're very much isolated and outside of the health and social care system at the moment, particularly healthcare.
We'll keep up that support, because it's certainly about 7,000 people. Could I ask another brief point, Chair? Notice in your briefing that your first statutory duty is to represent the interests of the public, as you say, to the health and social care system. Do you feel that being part of that system affects the way you carry out the function? Let me give you just a brief example. In your briefing, and you've outlined that section on waiting times, you describe them as being too long, and the information given to patients regarding waiting times leads to frustration and breakdown in trust of the system. Is it not the case that with 34,000 people waiting longer than 52 weeks for the first consultant-led appointment, that is an escalating and unprecedented crisis? Should the public expect maybe more use of language rather than too long and frustrated? Because this is unprecedented and a crisis. Are your words maybe too light, or?
Okay, so I think your question is around independence, if you're a part of the system, and I think it's a good question, and it's a question we've been asked for 7 years, repeatedly. The independence that we have comes from what people tell us. So our evidence is solely based on the work that we have done about finding out what groups of people think about particular parts of the service. And then it's our job to make sure that the system hears and responds to that voice. And we work really hard to make sure that we gather the information in an open and transparent way. I am not likely to go out and I will never go out and speak on a topic unless I have evidence from people who've experienced that topic. I think that the strength that it gives us from being part of the system is that we can be part of a discussion that people would not otherwise have the opportunity to be part of. So when Louise and I are sitting around senior policy tables, we're able to say, actually, I'm not sure that's a good road to take, because people who experience the service, find this doesn't work or that doesn't work, and that's the real strength of being part of the system. But we absolutely, we're conscious that the independence is a really important part of our work, and we guard it very, very carefully, as does the Patient Client Council Board.
And the use of the language, because you're the voice of the patients, as are we, as their elected representatives.
Yeah. I think the use of the language is interesting. I mean, I think that this came up quite a lot when we were talking about emergency departments sort of 18 months ago, when every Friday and Saturday night, come Monday morning, we were hearing about the problems in our emergency departments. And it was really important that the language wasn't making people worry who didn't need to worry, particularly around emergency departments. So when people were hearing about having very long waits, we were very conscious. We didn't want people who had a real emergency, for example, were in a road traffic accident and needed care, that they would worry they would have to lie in a trolley for 14 or 18 hours, which was not the case. The long waits around emergency departments were for people with often minor injuries. So we are considered about the language that we use. We choose it carefully. We use it in the right arenas. But I mean, I take your point that people are frustrated with waiting lists, absolutely. And again, we're working really closely with the system to look at different ways. One of the issues we have around waiting times is the information that is given to people about the waiting time. So when you have a consultant referral and the consultant or whoever says to the patient, you will wait 3 months to get an appointment, and then 3 months passes and the patient hasn't heard anything, and that's where the frustration really starts to set in and people start to lose faith in the system. What we think would be really beneficial if when people were being told about the length of time that they have to wait, that they were given accurate information around that, and we would like to see that information being available to people for different programmes of care. So currently in emergency departments you can go online any hour of the day and find out what the waiting times are in our ED departments. We would like to see that information on waiting times for diagnosis and for treatment and for outpatient appointments to be available also. That then gives people information to make decisions about their lives. Currently, if you think you're waiting 3 months, but actually you're going to wait 6 months or you're going to wait 9 months, then you have to think about your work life, your personal life, and actually if that 3 months isn't 3 months at all but is longer, then people start to get really frustrated with that. So that's where we feel there's a problem with waiting times. Of course there is, but there's also a problem around the information that people are given about waiting times, and I think those two things are equally important.
Thank you. Thanks, Chair.
Thank you. Just to pick up just on the back of that, to do with information in general, I know that, and I absolutely agree with you, I think that if people are given a more honest approach, they tend to be able to deal with things much better. But information in general that anyone is given throughout the health service, whether that's after a diagnosis, whether that could be in, on a care for the dying pathway, whatever that might be, is that becoming, or has that been highlighted with yourselves?
Yeah, that's something we have been raising since 2009 for sort of recurrent theme. Information is as much a part of your treatment as your medication and everything else. As you know, in England they have NHS Choices and NHS 24, and down south now they also have the HSE information online. People need good accredited advice and information about their diagnosis, about support groups, etc., etc. And also the staff need that to give to the patients as well. So we've been working alongside Health Social Care Board and the Public Health Agency over the last couple of years, and information has now started to be available on NI Direct. It's quite limited at the moment, and we're sort of frustrated with the pace of development of that. We would like to see a lot more there, but at least it's a start, having the information in the one place. We're currently involved in that, trying to get a lot more conditions onto that, because it's really important not only for the patients and the carers, but also for staff, that they're using the same information right across the system. So I really.
Yeah, I absolutely agree, because we have so much available now online and on the internet, and quite often a lot of that is not factual, or it's not exactly the right information people should be getting. So there needs to be more of a streamlined.
It needs to be that single trusted source of health and social care advice and information, and that's our vision. And that's what we want to see happening.
That's excellent. And another, just to tag on to that, is also communication between medical profession, nursing profession, AHP, social workers, whatever that might be, and that patient-client group. Has there been any further work done on that to improve that communication between the client and the professional?
Yeah, again, communication is one of the themes that comes up regularly in our work in supporting people to complain about health and social care, and it is exactly as you describe it. It's communication with the patient, it's communication between healthcare professionals. The Northern Ireland Health Record, the electronic healthcare record, is something that will be really help to progress better communication. And again, some of the feedback that we have had from people who have had experience of that is really, really positive, particularly patients with long-term illnesses who were finding they were having to wait for GP letters to come after they'd had a hospital appointment. They're describing to us that the information is flowing more quickly, and that's allowing their treatment regimes to the changes to be made in a more in a quicker fashion, which is better for them and their health. Yeah, so that has been a really positive addition.
And the one thing we want to see is that patients will be access to their own records,
Yeah.
and they'll be able to hold that, and that will make a huge difference. And we're actively lobbying for that as well.
Yeah, good. Okay, I have then got Jerry.
Thanks, Chair, and thanks for the presentation. Just in regards to the waiting lists, I mean, I think it's clear, like, you know, we've absolutely too many people on waiting lists and people waiting too long for treatment. I think there is a crisis. I think that's the correct definition. It seems to be every single week there's a new story breaking in the news and the media about it, and it's something that's constantly raised by constituents and myself, and I'm sure with other people. And I think the knowledge and expertise to reduce the waiting lists definitely does exist within the health service. But in regards to a question, kind of one area, but a few questions, if you wouldn't mind, in regards to the complaints procedure. Kind of what role and what sort of facility and support would you provide for people who have complaints? Have you found the complaints have increased in the last 3 to 4 years? You mentioned about bureaucracy. I think it's specifically in regards to young people who have complaints. Is that a general trend would you find? Could you maybe touch a bit more upon that? And just sort of finally, do you think there are effective mechanisms in place within the health service to adequately deal with complaints that are put across? And could you maybe sort of address those points?
Okay. Yeah, very familiar with all of the things that you're saying. Sorry, you go ahead.
Yes, with regard to our role in particular, we have a statutory duty to represent or support people who wish to make a complaint, and so the kind of things we do is we provide people with information on how they can make a complaint. We help them with drafting letters. Some people need help with drafting letters. We will make telephone calls. We have a helpline. We will make telephone calls on their behalf. We will support them to attend meetings. We will support them if they want their case to go on to the Ombudsman and to other referral bodies as well. And we facilitate a lot of contact with health and social care organisations with complaints. We do that on average for about 1,000 people a year through the formal complaints process, but we also support a lot of people through our helpline on a daily basis. And that heads complaints off at the pass quite often. Those are issues which we can resolve through 1 or 2 phone calls quite often. And that's something we set up in the last year, and that has been really, really helpful. What we find is that the health and social care complaints procedure, as it stands, is not a particularly bad procedure. But what we find is that the lengthy delays in getting responses is an issue for people. And quite a few of the complaints that we deal with, there would be a good number of them would be around the experience of people at the end of life. And for example, like sudden death in hospital or something going wrong, etc., etc. And sometimes then there's very slow responses, and that almost, in a sense, you know, you can be sitting beside someone who's grieving, but then the process itself has a negative impact on them, and that is something that we have been raising as an issue. We think, for example, where there's a sudden or unexpected death in hospital, it would be helpful if there was some means of talking to the people within a respectable period of time quite quickly, just to explain what happened, because sometimes people just don't understand what happened, and then that becomes very, very difficult for them when they're in the midst of a protracted grieving process as well. So the number of complaints overall in health and social care actually has gone down slightly this year. You're asking about the numbers of complaints, and it may well be that maybe local issues are being dealt with better within the Trust Suite, and we're not sure. But also we find the helpline is helpful in helping people to get quicker answers rather than having to go through a formal complaints process. But for those who need to go through the formal complaints process, we provide quite a comprehensive service to them, tailored to what they need. Some people just need the help. You know, how can I do this myself? They're quite empowered once they have the information. Other people need, you know, support to write letters, attend meetings, all of that, depending on the difficulty of the case and their own ability to do that. But we take referrals from MLAs quite often, and from other organisations as well, and from staff and from individual members of the public on a daily basis.
Okay, thank you. Paula?
Okay, thank you. Thank you very much for the presentation. I'm going to go back to the issue that Joanne raised there around ME. I've got a copy of your report. I wish all position papers were that comprehensive. It's absolutely fantastic. Last week at our strategic planning day, I had suggested, and I think it's something we'll probably come back to around maybe even this committee having an inquiry into the experiences of people who have ME or suspect they do. And I'm just wondering, is that the sort of support that you think you need, or what can we do as a committee to push this? Because I think it's scandalous actually that this is the only condition that doesn't have somebody there really championing it in terms of the network and support. So just wondering what we can do to support you to push this forward.
I'm not sure what inquiry in terms of reference if it would be or what. At the moment, we, the PCC, are in discussions with the Health and Social Care Board with a view to trying to get the most immediate need for these patients off the ground, which is the part-time consultant. Because we know that about 50% of people have the wrong diagnosis or don't have a diagnosis, and there's clear evidence base for that right across good academic research to support that, and that's been our experience as well. Even in formal discussions I've had with lead discussions within different specialties who have a bit of an interest in this, they would say that sometimes they get patients referred to them with ME. They discover then when they get their length after being on a long waiting list that they have something completely different. So that is there's a clear evidence base for that. So historically, this service was provided by a general physician, and general physicians are not, if you like, the way things are now within medicine. They're more specialised. So one of the difficulties we have is knowing, and which the Health and Social Care Board is working through at the moment, is, where should this naturally lie? In some areas of England it's immunology, in other areas it's rheumatology. Some services are still being provided by general physicians, but they're sort of a dying breed. So the most immediate need we have is to try to get a consultant on the ground to develop this service, because there's been no consultant for a period of time, and that would also support the GPs, as well as ensure people get a correct diagnosis. But we know from talking to people that some people, if they do get the right support early on, they actually do get better with ME, which is really encouraging. We know a few people who have made a remarkable recovery, yet we also know of people who have been housebound for 27 years because of this condition. So it's, and they're not a homogenous group, they're quite a heterogeneous group, and so therefore you really do need an experienced physician who is able to, it's a diagnosis by exclusion quite often, or ruling other things out. So this is someone that you need to have that level of experience, and our people are not getting that in primary care, which is the only service they have at the moment.
I think the point I would make, when I met with Health and Social Care Board over the summer, there isn't a dedicated budget for that consultant, and when they went out to expression of interest for it, at the deadline they didn't have any people coming forward on it. So I think part of the problem is that I don't think it's being properly resourced.
Yeah.
And we have been assured by the Director of Commissioning that the funding is there if they can get the person.
Yeah, but they found it as opposed to it being allocated. So.
I think it's quite important as well, when you have those very bespoke roles, that the awareness of what the expectations are of the role are made clear as well. In a previous position when I worked in palliative care and end-of-life care, it really was once we had consultants in post that whole specialty started to gain momentum. So we think that there's a gap, that this post hasn't been filled, and continue to work with Health and Social Care Board to encourage somebody to be in post as soon as possible.
Okay, thank you.
Thank you, Paula. Pat?
Thanks, Chair. Thanks for your presentation. I'm new to the Health Committee, so I'm still finding my way around.
Okay.
I just wanted to ask you about whether or not you can take a complaint independently of a member of the public bringing a complaint to you. I'll just give you an example. The case that's been in the media the past couple of days of the prisoner in Maghaberry who inflicted horrific injuries on himself, who had serious mental health issues. Could you off your own bat, go and raise that as a complaint without the family or the person themselves bringing a complaint to you?
As a complaint, so long as we have evidence, so long as and that's what we have based our work on in the past, and we have raised issues that haven't come to us specifically as complaints. So, for example, some of the work that we have done around endometriosis and ME is because groups of patients have come to us and said, look, there are issues here. Some of those will be making complaints, but the work that we have done has been based on information coming from a wide source. So in that situation, so long as we had evidence that that was happening, then we absolutely would take the opportunities that we have to raise that as an issue. Yeah.
I think it's important to highlight as well, we don't have the power to investigate. We will support complaints, but we cannot investigate. The investigation is with the provider body.
But you could use evidence gathered from another source. So, for example, in this case, the prisoner ombudsman gathered evidence. The prisoner was under the care of the South Eastern Trust, my understanding. So, in that situation, you could take that complaint forward or pursue a complaint without the person who was the who had been wrongly treated, or there was no real duty of care given to this person. You could pursue that complaint.
The other thing that we can do is, when we get our complaints information, is where we see themes coming through our work. So where we have, and again, that's right through all of our work, where we see things coming up more than once, then that will raise alarm bells in our work, and we will pick that up specifically with the individuals who are involved in that service. We do offer a service within the prison service, and we have had prisoners come to us in the past with complaints, and we've helped them to get them resolved with the South Eastern Trust.
And what happens in a situation where particularly a patient may have mental health issues and is incapable of bringing forward a complaint on their own? How would that be dealt with?
A mental health patient, not specifically a mental health patient in one of our prisons, or yeah. Well, again, we would have mechanisms in place where people. You don't always have to raise a complaint with us for us to take your issue forward. So lots of people who come to us say, I'm just a bit concerned. Actually, a lot of people will say, I don't want to make a formal complaint, but I do want the system to know that this has been my experience. And I think we work very closely within the Bamford Monitoring Group with service users who are accessing mental health services, and they individually would have a wide range of groups that they're working with. So the themes that are coming up through them, then quite often it mightn't be the person themselves who's had the experience, but they've been hearing that from the work that they've been doing. So we have different mechanisms in place where we can have it, and mental health is probably one of the areas that we're quite strong in hearing what the experience of people is.
Quite a few complainants who come to us would have mental health challenges, and so we actually would also access a specialist advocacy service sometimes to support our complaints officers to help that individual as well. We have a contract with an outside body who specialises in that, so where there's very particular acute needs, we will bring them on board to help the case as well. I think it's important that you know that service is there.
Okay, thank you.
I just add on to that, sorry, just on the back of what you were saying, Pat, as well, and I think it's good actually just to remind members in the room here as well, when it comes to health issues within prisons, it is then the Northern Ireland Ombudsman, not the prison Ombudsman. So there's a lot of issues around that sometimes we don't fully know about, and I would hope maybe we could get the Northern Ireland Ombudsman along here to committee at some stage to go through her role, and I know that you would be working with her as well on that. Yeah. So it's just worth reminding the committee that the Northern Ireland Ombudsman herself is responsible for a lot of the health side of many of our prisoners.
Can I just add one point in terms of what you had said as well, is that people in general are very reluctant to complain. The number of complaints is actually quite small, and even when they ring up to complain, they tell us what's really good about the service, first of all. And one of the things we have been advocating for is a feedback system, which will enable people to openly feedback what's good about the service or what their issues are without having to go through a formal complaints procedure. You know, we do that on all sorts of things in society nowadays, and we think that would be really valuable in terms of helping improve services as well. And we're in discussions around that as well at the moment.
Okay, thank you.
Thank you, Pat. Catherine?
Thank you, and thank you for coming today. And I know we've finally got our diaries aligned,
Yes.
so we will be meeting, and I do look forward to that as well. Obviously, the work that you do is invaluable, and I'm still learning very much. But just by reading the report, I can see that you provide such valuable services, both to the health service and to patients and clients. And often you can just offer them that wee bit of reassurance that maybe the deadline that they have been told has been and often just talking to people and communicating that to them. So I think the role that you provide is invaluable. My concerns are around health inequalities. People who are able to pick up the phone and complain will have their issue dealt with. But there's a larger number of people out there who aren't aware of the Patient Client Council, for example, aren't aware that they can pick up the phone and complain, and they're much harder to reach and probably much more in need than those people who are active and able themselves to lift the phone. So one of your statutory duties is to promote involvement of the public. So how do you engage those harder to reach people?
Yeah.
From day one, when we were established, we made a very active strategy, and Maeve was very strong on this, that we would not sit behind a desk. We would be out in communities. So we're at events, we're in local community centres, we're at agriculture shows, we attend community events. As we speak, our staff are out in shopping centres, they're everywhere, because we want to reach hard to reach communities and make people aware of us, and it's something we are constantly working on. And we've strove very hard. One of the things we did, for example, was to set up the membership scheme, which is made up of the man and woman in the street, if you like, who have an interest in health and social care, who can register online and keep in touch with us. We're trying different mechanisms through social media, Twitter, Facebook, all of that. We're constantly developing that and very aware of that, yet and all there are still people who don't know about us. But we're open to suggestions as to how to improve that. But it's something we're very actively engaged in. Right from day one, we go to the Mila Festival, we attend cross-community events, cross-cultural events. We're almost everywhere. You'll see our staff out with their green t-shirts, and with a view to reaching people who would otherwise not come into an office to talk to us or pick up a phone, as you say.
I think as well some of the issues we have raised have been the less heard issues, things like endometriosis, which are very high end symptoms for people, but they're not, they maybe don't have the numbers to warrant the very big profile that some, heart disease or cancer, some of the other conditions might have, and that's, we're picking up those issues because we are out in communities hearing from people. One of the areas that we don't hear a lot from are men. So again, not well researched that men do not talk about their health or their ill health issues regularly. So again, trying to create, and one of the examples is getting involved in the Men's Shed, the World Men's Shed conference is coming to Belfast.
Factories at lunchtime. You'll get factories.
And factories and things like that. So absolutely, we have not cracked this as much as we would like to have, but we are very, very aware. And again, in the last couple of years, we've been able to profile the people who have come to us. So we know now the numbers of between 18 and 24 people who are approaching us, and that is rising. We know the socioeconomic groups and all of that. So we've been able to capture that information, so we can start to have targeted campaigns in areas that we're not hearing from the amount of people that we'd like to.
And I think one of the things to stress that we're looking back on reflection, we're learning as we go along, that one of our greatest strengths has been providing a voice for those who historically haven't had a voice, and those are where we've had our greatest outcomes, like rare diseases, like older carers. Actually, we're actually a very silent voice as well, caring for people in the community, and people with chronic pain as well. They felt very isolated and very alone, yet now there were thousands of them once we started to work on it, we discovered. So, and also sometimes the people that you think are hard to reach are not as obvious, like older people in nursing homes rarely complain, and that's something we are concerned about. The complaints come from their families and their carers, and next year we intend to do a piece of work in nursing homes around older people, just to get a wee bit closer to their experience, because that's an area we would have some concerns about as well.
And it's just more of a comment, and thank you for letting me back in, Chair. And I'm heartened by the response, because I'm heartened that you are already actioning this, but also that you're aware that more can be done, and I think that's very positive to hear. My concern, I suppose, is in relation to the likes of men, people with mental health issues, the elderly who don't go to shopping centres,
No, exactly.
they don't go to community
Absolutely.
advice centres, and they don't have social media.
Yeah.
So what we need to do is ensure that's going to their home, and that might be something as simple as a leaflet drop, a call at the house with a clipboard, and I know that will require volunteers and all of that. But we do have a very good community out there, and many people that would be willing to do that. So it's maybe just an idea of bringing it to the home.
Yeah, and you know, older people in the community are quite heavily involved in church groups, things like that. So it's just understanding and targeting people where they're at in their world, and that's really, really important.
And in October, November, we're having meetings in every one of your constituencies with local people to talk to them about ideas about how we get more into that local community. There's a whole series of just like coffee meetings where we're just having a cup of coffee with people, and our staff are talking to them. I think there's about 20 meetings organised right across Northern Ireland in localities for that very purpose.
Thank you. Okay, thank you, Catherine. Gary?
Thanks, Chair, and that actually just comes on nicely to what I was going to say. And just thank you for the information that you do send through our constituency offices, because as MLAs we get lots of information through, some of it useful, some of it not so useful, but in fairness to yourselves, any information that does come through, it does take pride of place in our offices, and it's very, very useful indeed. You mentioned, and the Chair highlighted the sort of the issues around advice and information, and the fact that more and more people now are, Googling to see what symptoms they have. If they've a headache or whatever, they're Googling to see if they can get a diagnosis. And obviously, and it was touched on about ME as well, a lot of incorrect information is online. I think it is vital that we have a sort of a central location where we can go and we know that whatever information we get there is certified and that it's correct. And my question is, and you've touched on it maybe briefly, but how big a difference is there between the information that we can access here in Northern Ireland compared to what you can access across the rest of the UK? Is there a big gap in terms of the information?
This is different as day and night. Unfortunately, we still have a huge gap. In fact, when we started this, the Health Service Executive down south has now got more information than we have. It's been very slow because it's interdepartmental and it involves lots of different people. So it's been a slow decision-making process. We would have liked to see that much faster and much more available online at present. It started and we welcome that, but it's if you go onto NHS Choices in England, it's much more widely available and also much more user friendly at this point in time. But we live in hope that we will get there.
I think that's something we really need to take up, on the basis that obviously if the information's there, it's going to take the burden off other services where people can actually get it online without maybe having to go to their GP, or without having to maybe see a professional as well. And I suppose the issue around mental health and young people, is there any information maybe that could be passed through, the likes of an app, within our schools, that sort of thing? Is that something that you would be proactively campaigning for?
We actually did a project with young people about mental health information online, and that project is available. That report is available. There is a bit more information for mental health on the system than for other programmes as well. So it has moved forward a wee bit. It has moved forward a bit more than others. But we actually went out to young people in schools and talked to them about what was available online and how difficult that was to get to and what they would like. And we've shared that with the system. And that report is available on our website.
Okay, thank you, Chair. Just one last question. It's around, you had mentioned you support 1,000 complaints annually, and you had said in your report that health and social care organisations must find a way to listen to people when they have something to say. And people have to wait too long to have their concerns heard, which leads to formal complaints. And we as MLAs know that because we write off on a daily basis to the Trust. And we have that access in that we're members of the Health Committee, and obviously we're public representatives as well. How, could you give me, I don't expect an exact figure, but roughly, in terms of maybe a percentage, how many of these complaints could be sorted out before they reach a formal stage? Because we know that
As a target.
a lot of the issues that we have, they can be sorted out with a meeting, or they can be sorted out with a phone call.
Yeah. And again, we would see exactly what you're talking about in our helpline. We would know that if people phone our helpline, quite often it's about looking for information, it's about knowing how long they can expect to wait, it's about worrying in case, because they haven't heard anything, that they've fallen between two stools and they've been forgotten about. And if we can readily access that information and go back to the person and say, don't worry, your appointment's in the post or whatever. But that's the sort of thing can grow and grow and grow, and suddenly, that becomes a complaint. So we would know that, there's a lot that is done, can be done early on, that stops things actually becoming complaints, and that's really important. I mean, I think it is quite hard to put a figure on it, and I suspect that wards and outpatients are speaking to people every single day and sorting out issues, and that could otherwise become complaints. And that comes back to the piece there that you were talking about communication. If when people say I have a worry or I have a concern, if that can be helped as soon as somebody says it, then quite often lots of these issues can be sorted out for people. One of the other things that we've been looking at, and Louise alluded to it earlier, was a process by which we can hear about people's experience, that they don't have to go through a complaints process. And again, this idea of being able to leave feedback on a service that you've accessed. And again, this is we know that this is happening in other parts of the UK, where people can go online and leave their experience, and then that can be, services are picking that up and addressing those issues. So there are other things that we can put into the system to make sure that the communication is better and that people are helped. Because, people really do say, I don't want to complain. And they do come on to us and they say, let me tell you about my good experience. But, so it's not that people are setting out to make things difficult, but they just are, by the time they get to the point of complaining, quite often they're completely frustrated with the communication that they've had.
Okay, thank you.
Thank you. Trevor?
Thank you. Just going back to something Louise said in response to Catherine. Well, first, like Gary, I appreciate the stuff we get as well, and I'm very familiar, and I've seen you at many events. But in response to Catherine, you said, that I found it amusing, that you were concerned, particularly in the homes, that there wasn't many complaints. Is that a bad thing? Is it not necessarily maybe that the care has actually been good and there's nothing to complain about?
I think complaints are really useful insights into people's experiences, and not a negative thing. What we know is that families do complain and carers complain, but individual residents in nursing homes don't complain.
But who's important there?
The resident is important, but the issues that the families are raising are very important on their behalf, and not every resident has a family. So I think more people, and one of the things we want to look at is this next year, and we will know more about it when we actually get to look at it. But I think older people who are residents probably don't feel empowered to complain or raise concerns. Okay. And that is a concern for us.
No, that's fair enough. The other one, just away at the start of your presentation, you talked about the 4 consistent themes, and we've probably touched on treatment, communication, and waiting times. The one that nobody asked questions about was staff attitudes. So, of the 4 main themes, where does staff attitudes feature there? I know we maybe haven't got statistics for that, but
it's right up there. It's consistent. It's I can't tell you the percentage off the top of my head, but it's been consistently one of the #1 themes over the past 7 years.
So your 4 consistent themes, staff attitudes, is number 1?
Well, it's not #1. I just can't this year. Like I can't just tell you, but it's up there in the top 4 every year. And sometimes a complaint will have more than one theme to it as well. You know, the issues around communication and attitude often come together.
So in relation to that, I mean, and I think many of us probably heard of that even from our own experiences in our own offices, but what have you done as an organisation to try and address that one? Because that is a biggie. Because I think sometimes people do go with minor ailments, and the attitude and how they're treated sometimes can be off-putting for them.
We've done quite a bit. We've raised this, first of all, formally with the department and with the Health and Social Care Board, but also our staff go out and give lectures to, you know, social workers in training, doctors in training in the medical school, etc. And they give feedback on what people are complaining about, how that feels. Sometimes we bring a service user along. We think that's really important, that the young people who are being trained for the future also have some insight into our work. So we're linking in with the universities and the training colleges as well. It's feeding that into the system.
Are the social workers the worst?
He's saying that on purpose. You don't need to answer that.
I think the other thing around when people come to us to complain, they say they don't want, they want sort of 3 things. They would like somebody to say they were sorry, sorry for the experience that they've had. They don't want it to happen to anybody else, and they want the system to demonstrate that it's learning. And I think that you know that sort of communication staff attitude quite often go hand in hand, and we can see. And again, some of it comes out in our complaints report this year, where we can demonstrate outcomes from people having complained, where we've been able to go back to the system. And what has happened is there's been additional training provided in particular areas where communication and staff attitude has been raised as an issue, or trying to understand what the issues are, why people felt, you know, why people felt that, you know, people didn't speak to them or didn't communicate with them in a way that they thought was constructive. So it's about learning. You know, complaints should be viewed as a mechanism by which people can learn to improve the services. So it is about, you know, we're really sorry that you had that experience, but it's also about how can we improve the system as well. And complainants are absolutely clear when they're talking to us that, you know, that's what they want when they come to us.
Okay, thank you.
Thank you. Mark?
I had jotted down a wee list and it's been like bingo, bingo, not bingo, and what people weren't asking, what members weren't asking in the questions, you were still somehow managing to weave into your answers. I am familiar with the work of the PCC. I had actually been a member of one of your component predecessor bodies, the Western Health and Social Services Council, although I think it's fair to say that these have evolved somewhat since then and are much more than a conduit for complaints, and you've outlined a lot of the good work that you do around particularly raising awareness of conditions and bad conditions of the service that's meant to be in place for them. I'll start with the issue of complaints, and it's following up really from what Jerry had been asking. We know there are fewer complaints, or I've been told that there are fewer complaints this year. I'd probably attribute that to a lowering in people's expectations. However, it's the idea of this creation of a maybe softer interface whereby people can feed back into the system and share their experience. I know you're here and exists to represent the client and provide, or the patient, provide them with a voice, but it touches on staff attitudes as well. Do you sense a reluctance to go down the road of creating that type of portal, if you like, because of potential detrimental impact on staff morale?
Experience elsewhere would show that the opposite. That most of the comments, or at least 2/3 of the comments that go online on these real-time feedback systems are positive. That drives service improvement and motivates staff. At the moment, there is no system to collect positive feedback, no formal system here in Northern Ireland. The only stories that get out into the news are the negative ones. And this is about an open and transparent system which accurately reflects people's experience. We don't have that. So experience elsewhere would suggest the complete opposite, that this, you can have 2 wards, beside, we know from our work, you can have 2 wards beside each other with the same resources, but the experience of it is different. So no one wants to be in charge of the ward where there's less positive experience. That drives service improvement, and people want all the time to tell us about what's good about the service, but there's no formal way of capturing that.
No,
And at the moment, and we think this would be a really positive thing to do for health and social care.
I am aware of the positive experience elsewhere, but I was just wondering if you would attribute the failure of the department to go down that road here to, I suppose, an ignorance of that positive experience elsewhere. Another issue, just touching, I think, in your response to Joanne on the ME issue, it was around, I think he says there's a variation in GPs' understanding of ME. What steps are being taken, I suppose, to identify what that variation is and to bring those who have very limited understanding up to at least some sort of standard? So I know we're talking about the need for a consultant. That's something I very much support, but we do have to have a basic level of standard that people can access at GP
I understand that all GPs have been issued with the NICE guidelines. However, patients tell us that the NICE guidelines are somewhat out of date. They would like to see the international consensus model or the Canadian consensus model being adopted as the model, which is a more biomedical approach as opposed to a psychosocial approach. So what we've done is we've written to NICE and asked them to consider revising their guidelines, and they have said they're going to look at that next year. And we've also raised that with the Health and Social Care Board as well, and patients have done that through the support groups as well. And there is there's quite a bit of research going on across the world in the field of ME, which potentially has the ability to change that approach as well. But the existing NICE guidelines have been there for a while, and there is a feeling that from the patient's point of view that they don't meet their needs, so that has been an issue.
In relation to your question specifically around individual GPs, again, what we discovered when we started working with groups of patients who have ME is quite often they are a good source of training up GPs, and they have voluntarily been doing work in their own areas in terms of working with groups of GPs to try and raise awareness around the condition. So again, we'd like to see that all a bit more formal, but certainly we were really impressed with the level to which individual patients were taking this on board.
They're a very educated, empowered group of patients because they've had to be.
True.
Absolutely. And then finally, just you had touched on the fact that these will be next month or the following month out and about, meeting groups in 20 different localities. I was wondering, had you tied in with the councils in terms of the new function of community planning? I think there's clearly a role for organisations such as yourselves to play in that.
Yeah, and when the new councils were announced, we actually went to see all of the new chief executives to just have that very discussion around how, because I think over the years we have gathered an expertise around engaging and involving people, what works, what didn't work, and felt that the councils were keen to hear about that, to learn from that. So, and also particularly around their community planning. So we're working. Some of the councils we're working very closely with, others aren't as far down that road, but we have relationships with all of the councils in terms of being involved in their community planning. Yeah.
Okay, that's fine. Thanks, Lee.
Okay, finally, Robbie.
Thank you, Chair. And this will teach me, because I'm really new and I've come in last, and I think they've covered just about everything that was coming to my head. And you nailed it sort of at the end. But so, just first of all, I want to thank you for, and the Chair will thank you too, but I want to thank you too, because rarely have I seen anybody as well prepared and well covered in their portfolio. And also, as most people have mentioned, welcome the work you've done on mental health, and it'll be great to see how your this piece of work that you're on at the moment comes out. Look forward to that report. And again, but the one thing that I did pick up on, and sort of has been talked around, And I'd be very sort of efficient in how I would do business with people if I can answer the phone and deal with something. Sorry?
That's not what I heard.
When I was in the fire service, I was very efficient. So we can answer the phone, pick up another phone, and maybe bring a remedy very quickly. That's excellent. But the problem with that, obviously, is that if you get a recurring thing, and you did mention recurring themes, as sort of like forensic investigation into issues and problems. So my question then would be, you did allude that you do look out for that. What is your mechanism for doing that? What's the safeguard for a recurrent issue? Perhaps in and around, as Trevor was talking about, staff complaints, which is probably the number one thing that I would deal with, where you see a name perhaps pops up or a department that pops up. And how satisfied, or where do you get your satisfaction from knowing that it has been addressed appropriately then?
Yeah. We would look. We have a database, and we have developed that now. It's much more sophisticated than it was a few years ago. So our information is better. All our work is based on what's coming from people. So we're constantly looking at. Sometimes we would pick up not so much around individuals, but maybe a service where you maybe have 3 or 4 complaints. If we have 3 or 4 complaints, that's the tip of the iceberg, you know. So we would then link in maybe with the trust and say there's an issue here. We've done that in the past around one particular services that had an issue with pain management, and there was some horrendous practice going on with pain management. We were able to say, we think you have a problem here. And in the end, the people actually were retrained, the trust took that on board, and the patients and the service users were able to go in and talk about their experience and what that felt like. And that was a really powerful way of turning around the practice in that particular service. That's just one example, but you know, we're constantly looking out for, you know, groups and clusters of issues, and that's really useful for. I know the trusts do that themselves as well, but we would link in with them where there's particular issues.
Just one final one. I'm particularly impressed with your views on performance improvement and where the feedback system feeds in, and you see the have you, perhaps not your portfolio, have you been thinking about developing some sort of system that works alongside those that the HSE perhaps already has with regard to getting those?
Yeah, absolutely. Yeah, yes. And we're too small to create the solutions. You know, we're a small cog in a very big wheel, but and you know, we do punch above our weight in terms of making sure that, you know, we're with the right people saying the right things. So and as we say in the report, change is slow. It's much slower than we would like. So, but we are particularly in the idea of how do we just gather that good feedback, as well as addressing the issues where people have had a less positive experience, and we're working closely with the Department of Health and Social Care trusts around that. You know, we talk a bit about there being no more money in the system, and everybody recognising that. So it's really, really important that we take what we have and we make that fit for purpose. So, you know, it's about making sure that anything that is created, from our perspective, meets the needs of the people who have told us that they would find that beneficial, but also, you know, is reflective of what the system is going to, you know, improve things within the system as well. So we're really very, very conscious of that, and working really closely with the system about trying to come up with those solutions. Yeah.
There is a business case in for a system.
Thank you.
Okay, thank you. Thanks, Robbie. Ian, did you
Okay,
want to come in?
Chair, thank you very much, and thank you for your presentation today. No, leaving yourself to the end of the queue, I suppose, leaves you a little task. But I would like to ask, you know, you say that you're in existence basically 7 years, and over those 7 years, would you say that you've seen real change within the system? Some of the things that people would say to me is that when you bring a complaint against any system, right, you know, people close ranks, and you know, they defend themselves to the very end. Would you feel that experience, that there's resistance? Have you come across resistance within the health system, as we're talking about it today?
I think one of the things that we would observe over the 7 years that we've been in existence is that in terms of medical advances, that they have grown, you know, so you know, in terms of the amount of people accessing care and the type of care they're getting, that has changed. In terms specifically, I think there is a culture within the system where people now recognise it is a good thing to hear from people. It is and of course there is legislation around personal and public involvement anyway, that requires trust to make sure that they can demonstrate how they're involving people in their services and in the planning and the service delivery. So I think that has helped. But again, the frustrations that people feel are the length of time it takes for people to be responded to. So if I write a letter of complaint today or raise a complaint, then sometimes I wait an inordinate amount of time before I get a resolution to that. And again, I think there are many reasons for that, but certainly that's one area that I think people who complain would really appreciate earlier responses from the system in regards to their complaint. Because quite often what happens is you get this almost snowball effect. People haven't heard back from trusts, so then they get more frustrated and then they write again, and so things that probably could have been sorted out aren't, and therefore require a lot more resolution further down the line. So we meet regularly with the chief executives of the trusts, and we are raising the issues within the complaints, but also the issue of complaining and how that process could be made better. And I think the trusts are trying to put in place some mechanisms. I mean, we know of one trust now that who will give people a phone call when they get a complaint, particularly, as Louise described, if it's around end-of-life care. They'll ring people and speak directly to it. Because at the end of the day, we're all human beings. We all like face-to-face or at least voice-to-voice communication. And it's about, just taking, sometimes it's about taking a more compassionate approach to complaints rather than it being just a bureaucratic process. But actually, it's a bit like waiting times. Behind every complaint, there's a family. Yep. And behind every complaint, there's people who are suffering, and that's what we should be thinking about in terms of complaint. Not, oh, I have another complaint, I need to get this response out in 5 days, or else I've missed my target. Yep. So it's about that compassionate approach. I think to complaints is the next kind of piece of the jigsaw the trust needs to take on board.
Another thing, just to Ian, just to follow up on your question about over the 7 years, what have we seen? And I think it's fair to say that we've seen much greater involvement of patients and service users in decision making, and where that happens, it produces really good outcomes. And some of those will be in the report. We've summarised some of those in the report, which you'll get in the next couple of weeks. Even fibromyalgia event on Monday, where we had leading experts in the room with patients and their carers and clinicians and decision makers working to design a new pathway. And that is really good to see that happening. We see more evidence of good design, and that, at the end of the day, none of us have all the answers, but where you put people in the room with the lived experience alongside the people who have the experience in terms of academia and learning and all of that, and decision makers, that brings about the best outcomes, without a doubt. And that has been a big shift in the last 7 years. There's much more evidence of good co-design and co-production in place. We would like to see more of that, but involvement is much more to the fore than it was 7 years ago, and that's very positive.
Yep, thanks very much, Chair. Thank you.
Thank you, Ian. And can I thank you, Maeve and Louise?
Thank you.
Certainly has been a very in-depth and very informative brief, and I know from in the previous mandate you were most certainly a very useful source, not only as a member of this Health Committee but also as a constituency MLA, and we really do appreciate all of the work.
Thank you very much.
And that
thank
you
you.
do, and the work that you do with us as individuals as well. So thank you.
Thank you. Thank you.
Okay. All right, members, you'll know from your packs that we have some subordinate legislation that we need to get committee approval with. So if we can just move on to that now. Members will see that item 5, 6 and 7 all flow from the Food Hygiene Act, which was passed earlier this year. Included in your pack are the Department's proposals to bring forward orders and regulations to implement the Act in terms of practicalities, transitional arrangements, fees and fixed penalty amounts, By way of a reminder to new members, we're being asked today for our views on these SL1s, our policy proposals, and whether we're content for the Department to go ahead and draft legislation as proposed. So if I could ask members to turn to item 5, it can be found on pages 127 to 151 of your meeting pack. The first proposed rule will set out details regarding implementation of the Act, including the form of stickers, where and how they should be displayed, exemptions and details for the payment of fixed penalty notices. It is proposed that the rule will come into operation on the 7th October 2016 and be subject to negative resolutions. Have members any issues they wish to raise on this item? That being there's no issues raised, are members content that the Department makes this statutory rule?
Great.
Thank you very much. Moving on to item number 6, SL1, the Food Hygiene Rating Transitional Provisions Order, Northern Ireland 2016. Can I refer members to pages 120 to 125 of their meeting packs? This SL1 would allow district councils a 1-year transitional period during which they could treat an existing rating as the food hygiene rating for the purposes of the new Act. By October 2017, all relevant premises would have to be given a new rating under the Act. Again, it is proposed that the order would come into operation on the 7th of October 2016 and be subject to negative resolution. Have members any issues they wish to raise on this one? No. Okay, there being no issues raised, are members content that the Department makes a statutory rule? Thank you, members. Moving on to item number 7, SL1, the Food Hygiene Fee and Fixed Penalty Amount Order, Northern Ireland 2016. The third set of papers on food hygiene rules are at pages 113 to 118 of your meeting packs. The Department is proposing to make a statutory rule to specify the fee associated with a request for re-rating inspections and to set the fixed penalty amount. The order will be laid before the Assembly under the draft affirmative procedure, and it is anticipated that it will come into operation as soon as possible following the draft affirmative process. Have members any issues they wish to raise on that? Okay, there being no issues raised, are members content that the Department makes a statutory rule? Very great, thank you, members. Okay, moving now on to item number 8, which is the SL1, the remuneration of the Chairman of the Northern Ireland Medical and Dental Training Agency Regulations, Northern Ireland 2016. This can be found at pages 152 to 157 of your meeting pack. The proposed statutory rule is to be made to correct a legal anomaly which cast doubt upon the authority of the Department to remunerate the Chairman of the Northern Ireland Medical and Dental Training Agency. This rule is to be subject to negative resolution. Do members have any issues they wish to raise? Okay, no issues raised. Then can I ask members, are they content that the Department makes a statutory rule?
Yep.
Thank you very much. Moving on to item number 9, SL1, the General Dental Services Amendment Regulations, Northern Ireland 2016. Can I refer members to the relevant papers at pages 153 to 164 of your meeting pack? The Department is proposing to make a statutory rule in conjunction with the Department of Finance and Personnel to amend the General Dental Services Regulations 1993 by making 2 minor consequential amendments to the principal regulations. The rule will be subject to negative resolution. Have members any issues they wish to raise on this? No. Thank you, members. No issues raised. Can I then ask that members are content that the Department makes a statutory rule?
Great.
Thank you, members. Moving on to item number 10, SL1, Optical Charges and Payments Amendment Regulations, Northern Ireland 2016. Can I refer members to the relevant papers at pages 113 to 118 of your meeting pack? The proposed amending regulation will increase by 1% the value of optical vouchers issued to certain patients depending on their financial circumstances to help towards the cost of glasses or contact lenses under the health service. It is proposed that the rule be subject to negative resolution. Have any members any issues they wish to raise on this? No issues raised. Can I then ask members, are they content that the Department makes a statutory rule?
Yeah.
Okay, thank you, members. That's our statutory rules done. And my tongue is now getting very, very tired after that. Okay, we're going to move on now, members, to our Forward Work Programme, and that's item 11 on our agenda. Can I refer members to the Forward Work Programme on pages 171 to 172 of the meeting pack, and it was have been mentioned earlier to do with the pending publication of the Professor Bengoa report, and you'll notice that that was deferred from some of our briefings that we previously had penciled in, and given the Minister's announcement that she will be publishing her own vision document alongside the Bengoa report, our members content that we write and invite the Minister and Professor Bengoa to brief us as soon as the reports are published and to request an indicative timeline for this. Members
Chair,
content?
very much so. We'd expected it today, and I think sooner rather than later. I know we're not scheduled, we're just waiting. There's nothing in the forward work plan right up to November, so time is of the essence, so very much support that. I'd like to know where the delay has been to, if that could be teased out.
All
Where
right.
it's been with the Minister.
Well, we can ask that whenever the Minister comes
Executive.
along as well, but the members agree that we should have the Minister along with Professor Bengoa to give an evidence briefing when that report becomes available.
I think it's important there's no unnecessary delay, but we want to be, I think, give ourselves as individuals and parties and as a committee maybe time to digest the report
Prior
before
to.
a session on it. So you don't want it published on a Monday or Tuesday, not
Yeah.
have them in on a Thursday either, so we might need to be.
I would be in agreement with that as well.
We need the
But
time scales crucial.
well, that's what we're asking for. So we want of the Minister a timescale of when we can expect to have this before us. Does members agree with that?
Sorry, can I just ask, is it normal in the case of an independent report like Bengoa's report that the Minister would come at the same time? I'm just thinking, because it's such a crucial piece of work, you know, it'd be like that time we had the Chief Executives plus the Chief Medical Officer, that just too much, you know, could it be spread over?
We're at the hands of the committee. It's up to the committee what way we decide to do things, whether we decide to have both witness sessions on the same day or whether we do them.
Well, you know what, first of all, it's the background. I think Mark touched on it earlier about thinking behind it and the presentation of the report. And then I think a separate session from the Minister in terms of how she's going to deliver on it or interpret the report, because it's not a Health Department report, it's an independent report that was commissioned by them, and there is a subtle difference there.
Yeah, and we will be able to ask those questions of Professor Bengoa about the independence of the report and his findings, his recommendations before, I'd imagine, we would speak to the Minister. I think that would be the way around you want to do it. Okay, all right, members, well, we'll take that on board. And sorry, do you want to come in on that, just
I'm just going to check with members what kind of gap they would like. Are members saying you would like, for example, a 1 week gap
between
post-publication and having Professor Bengoa, and then another week before you would have the Minister, or what? We need a proposal, really.
Only thing that worries me, or not that it worries me, is that whenever this publication does become, the Minister will set out her vision automatically. Whenever this becomes public knowledge, you know, do we want to leave that any length of time before we want to drill down and question on that?
Chair, I mean, I have no difficulty with the break between the report and Professor Bengoa, but I actually would still rather have both on the one day, because I think whenever we've had him and the opportunity to question him, then with the Minister straight in, everything's fresh.
That's true.
I mean, I'm sort of comparing this with PAC. If you actually leave that longer break, then you have lost you have lost what you're bringing from Bengoa that day, and you're leaving it a week. As well as that, let's be honest, the media have digested what Bengoa has said and have come to their own conclusions before we actually have our interaction with the Minister. So, personally speaking, I would prefer, I think the committee should get the report before it's entirely published to the public. And then our opportunity, I mean, if they want to publish the report the same day that Bengoa comes, but I would prefer to see Bengoa and the Minister in the one day.
I would probably be in agreement with that as well, because it is fresh, and it also has, it's not giving, maybe this is being disingenuous, but it's not giving the Minister time to some of the issues then that are brought up by Bengoa. So we need to be reaction, you know, we need to act fast upon what Professor Bengoa brings up with us.
Well, I think the suggestion I would make off the back of that would be that it would be separate. You know, that Bengoa would come in, might have a 10-minute coffee break, and then.
Well, that's the way it will be. They'll not be together.
I thought you meant
on
the same panel.
No.
Right.
It will be two separate briefings, I would imagine, or we can ask for two separate briefings if that's. Sorry, Paul, I got to take that wrong. I thought you wanted a break of even a week.
No, well, it is a time. think that we need to separate the report from the Minister's vision in some
Absolutely.
ways.
Okay, nope, that's fine. All members in agreement with that then, that whenever we receive the report, we allow ourselves time to digest that before we bring Professor Bangoa and the Minister forward to committee, and we ask for separate briefings from them.
Right. Provided the Minister agrees to holding the publication until we, close to the date that we have been going.
Okay, well, we can
Because,
go back and
again,
ask.
if the media have a week before our meeting, well, everything's in that's going to be in,
We need to have it first.
yeah.
Yeah,
Very much
okay.
so.
Well, we can certainly write to the Minister and ask that, so we can. Okay, members, if we go back to the Forward Work Programme, there's nothing else I need to bring up on that. Are members content to note the remainder of the Forward Work Programme?
Noted.
Thank you. Item number 12 is matters arising, and can I advise that I have no matters arising? So I'll move on to item number 13, which is correspondence. And again, if you can just bear with us on this, because we've just come back from summer recess and there's a mammoth amount of correspondence. So can I advise members there are 46 items of correspondence at pages 182 to 713 of your meeting pack. The correspondence cover sheet at page 177 to 181 sets out proposed actions. And can I draw members' attention to a number of these items first? At 13.3 on page 201 of your pack, a response from the Minister to our inquiry about the independent guardian regulations and when they would be coming to committee. The Minister states she is still considering the matter. Can I suggest that we go back to the Minister and seek information on her anticipated timeline on that as well?
Yeah, good practice to get
Great,
into.
thank you. If I can then ask members to draw their attention to 13.13 on page 303 is a holding response from the Minister to our inquiry about engaging on the programme for government and budget process. Are members content that we go back now that the summer is over and seek a briefing on the outcome of the consultation or an update on this?
Yeah.
Members agreed? Thank you. Then can I ask members to look at 13.29 on page 444 of their pack, and this is a request that this committee sponsor an event for ASMA UK in Parliament Buildings on the 3rd of November. Are members content that the committee sponsors that event? Okay, members, that's all I have to bring up on that for now. Are members otherwise content with the proposed actions as listed on the correspondent cover sheet at pages 177 to 181? Sorry, Jerry, go ahead.
Yes, Chair, just a question. 13.9 286, the fatal abnormality working group. It was my understanding that we were to get a report in September, if I'm correct. Can you confirm if that is the case? And also, do we get the report and make a recommendation, or what is the process? And if we were to get the report in September and there's a delay, can we find out why that was and when we'll be getting the report? So just a query on that, Chair.
Okay, Elisha, have you any further information on that?
If I can refer members there to the 13.9, it's on page 286 of your pack. So the working group has been established and terms of reference are there to let you know how that group will operate. At this time, the committee may wish to consider its options. It could consider seeking a briefing in due course when the committee has had a chance, the working group's had a chance to get set up and begin its work. I imagine you may wish to consider whether they would have much to report to you at this time if you were to call them forward, but it's in the hands of the committee how you wish to proceed.
So it really, I mean, do we want to get them in straight away, or do we want to leave them and give them, say we do it before Christmas, definitely? Get them in maybe near the end or of before we break for Christmas recess?
The question is just, it was due in September, so it was kind of finding out, has there been a delay? Well, unless it's due in the last 2 weeks, and then why is the delay, and also when are we going to get the report, really, is what I'm trying to query.
Well, we can write and inquire about those issues, but I definitely, if members are in agreement, we can bring this up again with the view of having them come back and give us a more in-depth briefing prior to Christmas recess. That gives them a little bit of time to get themselves established and maybe be able to give us a bit more information. But on your issues, we can write and ask those questions. Paula?
It was useful to get the terms of reference for that working group, and I was just wondering if we could request a copy of the terms of reference for the Health Strategic Partnership Forum, which the Health Minister has established to inform her Bengoa report. This is the one where they'll be working with trade unions and representatives from the health and social care. She announced it in the summer. but again, there's no terms of reference around how long they're going to be meeting, what they're meeting about and stuff. So if we could have a copy of those terms of reference too.
Okay, that's fine, we can ask for those. Okay, members, other than that, are members content then to note the actions, or agree rather, the actions that are listed on our correspondence sheet?
Yeah.
Great, thank you. And can I also draw members' attention to the memo at page 714, detailing reports received by the committee office during recess. These are available on the organisation's website, and a hard copy is available at the office. Members, I'm now going to move on to item 14, which is any other business. Go ahead,
Sorry, Chair,
Joanne.
I have a couple of points, if I may. The first one follows on from Bengoa. I think we should also be concerned about the Finance Minister's recent statement about another one-year budget, because I would like to ask the Minister for her view on that as well, given the inevitable impact this will have on any reform proposals.
Okay,
So
no, that's a
maybe
good point.
write her and ask that too.
Yeah.
Another point I wanted to raise, if I may, is Zika virus. The confirmation yesterday by the PHA that several people have been diagnosed with Zika virus. Obviously, public information is critical at this time, given the link between the virus and the underdeveloped brains of newborn babies. So could the committee maybe request an update from the Minister on the action being taken following diagnosis, and also what the department is doing to monitor the development of treatments and the spread of the cases? I think they said less than 5,
Yeah.
but I think the public needs to be informed. We need more information of that. So could we request that maybe as well?
Absolutely. Yes, that's not a problem. Members, anything else they want to bring up under AOB?
Just one point. I could have maybe brought it up under forward work plan. There, I don't know. Are we due another monitoring round?
We can find out. We're writing to the department anyway. About
Well, it was on that. And might we get some information around any bid in the event of one from the Minister? I mean, we didn't get any detail around the department's last successful bid for 67 million plus, well, we got the 5 million capital breakdown, but it was my understanding that there was actually a statutory requirement to bring details of the bid to the relevant committee.
Okay, we can put that into writing to the
I
department
mean,
and find out.
it's ridiculous to expect committees to scrutinise departments when we're not getting sight of vital information like that.
Okay, Mark, that's been noted. Okay, any other business members wish to bring up? Okay, can I just remind members that the Mental Health Rights Campaign will be here for photographs on the steps immediately after committee, so if members, when we finish, can head out that direction, they want to meet with us. And then I'll move on now to item number 15, which is date, time and place of next meeting. The next meeting will take place at 10:30 next Thursday, the 22nd of September, here in the Senate Chamber.